So no matter what your focus is on healthcare, whether you're a software provider, a provider of clinical service solutions, you call yourself a technologist, you're a clinical provider, at the end of the day, the message of much of my presentation is going to be around never forgetting the patient and how complex it is to actually truly engage and connect with someone with all of the complexities that's going on with their lives, with their backgrounds, with their support services or not, and how different it can be. And so the next time that someone tells you a bot or a chat bot or a digital health platform is the answer, remind yourself that it isn't, right? It is a piece of a solution, and we, in my view, continue to try and find easy ways to solve incredibly complex problems, and we do it from the boardroom on out instead of the patient on up, right? And so the concept of always trying to map solutions, whether it be a patient journey, from the eyes of the patient, which is no different than CPG marketing with the eyes of the consumer, is something I think our healthcare system, it tends to forget. And that's the message that I'll continue to build on during the course of my comments. And this is an example. If you go back some years with the meaningful use requirements that went into place from the government and the advent of EMR, we ended up creating an unintended consequence. If you think about the concept of an EMR, makes pretty good sense, right? Create documentation, to create longitudinal documentation to allow for the ongoing and meaningful collection of touch points and data along the way, right? This is what happens in the patient room as a result from the unintended consequence of not thinking through what could happen in an environment where there are reduced resources. Hence, you don't have, I mean, we had scribes pop up for a period of time, and then the concept of paying for scribe services, I don't see them as much, but you had companies pop up that did scribe services that sort of followed the physician along the way and took notes, right? And those are still out there, but I don't see 50 of them. I see one of them or two of them. What you see is this, and at the end of the day, you got a patient. I've been in physician rooms myself. You talk to the back of their head. And then they're upset that they can't then engage their patients in the 8 minutes or less that they get in a primary care setting. And so, again, technology at its core with what they were trying to do with EMR, good. Unintended consequence of forgetting what it could do if not managed appropriately from the patient's lens, bad. This problem, for those of you that are on the sort of periphery of healthcare, you'll read about this 50 different ways. Half the room will appreciate this. Often things are fake news. And at the end of the day, it's hard to interpret what is real anymore because of the spin that's coming from our folks in Washington on whichever side is speaking that day. At the end of the day, the numbers don't lie, however. The population of 65 and over patients is going to nearly double over the next 20 years. And we're going to wake up in 2030 with nearly 1 out of every 5 people in the United States of America being on sort of what we call today Medicare, who knows what we'll call it in 2030. And we are not solving the problem, right? And so the problems are maintained at best, getting worse usually, and the funnel that's feeding into the broken system, if you think about a pipe, right? The amount of water entering that pipe or people is growing, and the pipe is rusting, right? And there's no end in sight. And so we do have an urgency. I think no matter what side of the aisle you're on in Washington, people agree with the urgency, but I'm not sure we're making much progress, and that's an unfortunate statement to make. And as you look at sort of the top of a pyramid, if you look at population health type literature or just someone that's sick people are sick. Sick people consume more of the resources, so much so that it can be in upwards of 5 to 7 times more costly when you get into the complex population. So I started, I've been through many lives. I was a physician by background, started my career, I got an MBA, ended up working in biotech on the cancer side for 8 years, went back to Pittsburgh, joined an integrated health system, a payer-bought health system, created an integrated payer-led health system called Highmark Health. And I started on the health system side in 2013, what's called the Allegheny Health Network now, and I was handed the project of constructing a post-acute care model. And I remember, because I came from the West Coast in California and I got a lot of flip-flops and jeans, and now I was in a suit culture. I went to buy some nicer clothes and I said, I'm working for the Allegheny Health Network. They said, who's that? Because it was new. And I said, you know, I'm doing this post-acute care thing. And they said, what's that? And I said, I didn't know how to, it wasn't a noun, right? And so you had providers like home health care and skilled nursing facility that would identify as being a provider of post-hospital or post-acute care, but it wasn't a noun, certainly not a strategy, certainly not something that payers, insurance companies, and health systems were thinking through. And not a year later, 2014, 2015, folks felt that the answer to what all cures or ails healthcare is population health. So then you had health systems around the country hiring population health officers. And I didn't quite get it, because population health is the air we breathe, right? And post-acute was the patient is in the hospital. They're there. They're in your home. Something has gone wrong. Why not solve for the problem from the inside of the hospital on out versus try and fix the air we breathe with population health and try and prevent people from coming to the hospital? So with all the, just picking a segment, skilled nursing facilities, with all the pressure on skilled nursing facilities, all the technology companies out there trying to restrict the use of skilled nursing facilities, the utilization change in the MedPAC reports over the last 5 to 7 years has been a reduction of 1%. Right? The concept of fixing the air we breathe doesn't make sense. Picking something a little smaller and sort of going after it with all we got is a strategy in healthcare we typically tend to skip. It's like, how do we fix the air we breathe? If you're developing a platform or technology or a solution, if your business objective is to fix the air we breathe, I don't think you're going to be successful, versus being very specific in terms of a subset of the problem that you can then sort of mushroom from there. So you don't hear much about population health officers anymore. What you hear about is patient experience officers. Because at the end of the day, now healthcare has recognized that we're not engaging the consumer in the right way. And I spoke to a reason why I asked about CPG marketing is, let's take a look at consumer product goods. The word consumer is in the name, right? Who's the consumer in healthcare? And I'll get back to that rhetorical question in a second. CMS, the government, and Seema Verma has done an outstanding job, I think, in branding what the objective should be, and that's creating a healthcare model in which it is patient-centric. And this is just a subset of hundreds. If you went on to Google and did a search on patient-centered or patient or consumerism, there is a big push for the new nomenclature, not the air we breathe, pop health, but really patient-centered healthcare. And at the end of the day, I think that's great, except here's the problem. In healthcare, unlike consumer products goods, I don't know who the consumer is. You've got to be very careful when you actually try and define a consumer mapping exercise for which your software solution service, this, that, and the other is trying to aim. And so here, let me give you an example. If you're developing an app, that is, the vision of the company is to provide better patient engagement, and you license the app to a health system so that they can manage their patients after discharge for a period of time. There are 150 of them, right? There's 500 of them. They're everywhere. Here's an app. It will allow the care manager in the hospital that does not have time to use the app to manage a patient population after discharge for a period of time they don't get paid to do anyway. Okay, sounds interesting. Who's the payer for that? The payer for that, really, at the end of the day is, and there are many permutations, but I'll just pick one, is typically the insurance company. The insurance company, whether it be CMS on the government side or the commercial payer, I presume you have a Blue Cross Blue Shield plan in North Carolina, will pay a hospital a DRG or a set rate for a period of time that condition, the patient with a certain set of criteria on their diagnosis is in that hospital. So if you're an app and you want to license it to a care manager in the hospital to use to manage populations, the payment is from the payer. The purchaser of the service or app is, it can be many different people, I'm picking one, is the hospital system, right? The stakeholder or the person making the usage decision is in many cases going to be the family member or the caregiver. And the end user will be the patient, who is either paying a small fraction of it, a copay, right? Or in many cases, particularly on the drug side, nothing. So how incented will you be in the purchasing decision if you're not paying for something, which is a whole set of behavioral economics type research, which is super interesting. So if we want to create patient centricity, I'm all for it, right? But let's be real about the complexities of creating patient centricity when the payer, the purchaser, the stakeholder, and the end user are all different in healthcare. Let's talk about the users, okay? Sadly, I've worked in most of these fields. I don't know how I did that, but it seems to be my career path. Let's talk about where they have been and sort of think they are and what they're trying to be, but don't know how to get there, right? Left side are fee-for-service, right, or cost-oriented entities, sort of, right? The right side are entities that are more value-oriented. Let me be, again, many definitions. Let me pick one way of describing it. The right side will pay for stuff if it saves them money. The left side doesn't want to pay for anything. And I'm oversimplifying, but for the purpose of being illustrative. And let me give you a sub-example. A hospital paying for something that reduces readmissions, which everyone wants to do, reduces admissions, reduces hospital census, reduces revenue, reduces job security. So if you're not being paid to pay, that's why hospitals are a very difficult segment to sell stuff to. On the right, an ACO, an accountable care organization, gets to keep 50 cents on every dollar, right? If you're a payer, you collect premiums, you own 100% of the premium, you can then invest out of the premium dollars in stuff to save you money. If you're an ACO, an accountable care organization, which are Medicare sponsored, if you save money compared to a baseline, you get to keep 50 cents. So there's even less money to invest in things when you only get to keep 50 cents and you got to invest in some stuff that you're not even sure will save you enough money to get to keep 50 cents, right? So there's all kinds of stuff going on here. So let's talk about this though. Hospitals, and I don't know the Charlotte market, I've been to Charlotte a lot of times, but so few times out of the airport. Charlotte, and I don't know the dynamics here, well, I'm sure has atrium hospitals. And in the old world and really the current worlds, they're paid on service, right? They deliver a service, they get fees for it, fee for service, right? But, and I believe it has recently happened, Blue Cross Blue Shield of North Carolina, which Patrick Conway runs, now he's running Cambia. There's a lot of stuff going on here. They have created, I don't know this, you probably know this a little better than me, but I read a little bit about it. They created relationships with hospital systems so that the care of a Blue Cross Blue Shield member under the eyes of Atrium will be paid differently if savings are achieved for the member. It's like tango web here. So if a congestive heart failure population sought care in Atrium over the last, I'm making this up, over the last 2 years, and the average cost of that heart failure population was X, if Atrium is able to continue to deliver care for CHF heart failure patients, which they'll get paid for with a rate, maybe the rate gets lowered, but if they save money for the health plan lower than X, the concept is the health plan will pay them incentives. And the incentives plus the base rate will exceed what they would have made in a fee-for-service environment. Is that clear? So you'll see more and more of these. In fact, the common question that gets asked now is, what % of the population is under a value-based arrangement? Or how much of the payments, which is code for fee-for-service payments, are being shifted to value? But if you're a health system, you will have a mix of Medicare Advantage type arrangements through health plans with fee-for-service through Medicare, right? Medicare Advantage are commercial health plans that have sort of these Advantage type plans that are Medicare Plus. Medicare is through the government. And there are demonstrations and pockets of value-based opportunities, but for the most part, with exceptions always, a lot of Medicare is still fee-for-service. And then you have Medicaid and this, that, and the other, and other commercial insurers that aren't there yet at value. So you can't just do fee-for-service, but you can't also jump into the pool of value, right? So they're in a very difficult environment where they've got to continue to operate under fee-for-service sort of mindset, but be very, very open to and aggressive to positioning for value. The types of employees, technology, infrastructure required to be successful in value-based arrangement is chasmically different. So you're asking organizations that are cash-strapped to invest with money they don't have, to prepare for models that may or may not come, while also operating in the current environment that will keep them solvent. So I'm back to how I started. Everyone wants to do the right thing. CFOs want to do the right thing. Their mother, father, sister, brother, neighbor, you just hear the stories, are consumers, and they don't want the wrong thing to happen. They don't want to create readmissions. They don't want to not invest in things that results in better care, less utilization. But I'm in plenty of meetings where we're talking about the poor flu season or the good flu season, or I really hope the weather turns cold, because cold weather generates admissions. And so it is a very, very complicated environment of good people trying to do good things that are subjected to a really, really complex situation. Let me just illustrate another example, again, for all the tech folks in the audience trying to create the app that changes the world or the air we breathe, that there is major barriers to the right thing happening when you look at the hospital to post-hospital or hospital to post-acute transition. So much so that to change the air we breathe, I'm not even sure is realistic versus meaningful, sort of smaller scope, less ambitious, which drives me nuts, but to even say that, but less ambitious, more depth, less breadth type of solutions that can create anchor points that we sort of grow from, right? So you take a look at a hospitalization, and I'll pick a stroke population. Someone has a stroke. They are in all likelihood, I shouldn't say all likelihood, but many of them will end up in a stroke center, and let's just say in an academic medical center like Atrium. If you go, you'll have an acute care stay, and then mostly you'll see folks that are not ready to go home. So they'll go to some form, I have some acronyms on here, IRF is inpatient rehab facility or rehab, right? Rehab are folks that can't go home. They're either freestanding, you'll see buildings that are rehab facilities, or rehab units within a hospital called acute rehab units. In both situations, they'll receive, I forget the number of hours, they got to have like 3 or 6 hours of therapy in order to qualify, and they'll get that intensive therapy before then being moved on to a lower level care. So they'll go from acute care stroke center to either in the building or outside the building, another facility. And then many of them will end up in skilled nursing facilities, ultimately going home under the care of home health care, which is another reimbursable service. And then they'll be, hopefully, if they recover to a point of independence, will now be in their home, sort of achieving whatever base line of wellness or health they're able to. What I described is hospital to IRF, IRF to SNF, SNF to home health care to home, 4 transitions of care, all siloed, fee-for-service oriented businesses, right? All not incented to, not paid, when I say incented, paid to manage the transitions to the next level of care. None are, I shouldn't say none, most of the time they're not paid to make sure the meds the patients get in the next setting match the meds they wanted. I worked in hospitals now, I don't know, 15, 20 years ago, whatever it is, but apparently discharge instructions haven't changed. It's discharge to home, follow up with your PCP in 2 weeks, here's 2 weeks of meds. When you do that for an 85-year-old, what do you think is going to happen, right? And I'll get into what we're doing with Lacuna, but what happens when that patient who didn't hear you saw the click and click video, this is not the time to be giving lots of instructions, right? Yet that's what we do at the point of discharge. So they go home, they lost the discharge planning paperwork. 6 meds bottles are on their mantle when they get home that they forgot to bring to the hospital, didn't recall, didn't tell anyone. Now they may have received duplicative stuff with contraindications, and no one is there to make sure that those 6 meds are the right 6 meds with the 5 meds that they got at the hospital. Then when you go to each successive setting, you're going to get med reconciliation again, because these settings are typically under the care of their own vertical medical doctor in order to be licensed, right? and now you got a mess, right? So if we want to fix readmissions, have at it, right? But in order to control for a 30-day readmission reduction program, and you're selling a solution to a hospital, I heard it all the time when I was the purchaser, and now I didn't want to do this to myself, but now I'm the seller, right? And so at the end of the day, when you're in there selling, that you can change the air we breathe, no, you can't. Because to control for a 30-day readmission reduction, with the way the lengths of stay are working, they're going to go to an IRF for 15 days. Let's say they go to a skilled nursing facility. It's 15 to 25 days. Home health care is 45 days, 30 to 45 days. My point is, you can't run from the fact that you're going to have to control the transition as well as connecting the dots across the various settings for a long enough period of time to truly be able to change the air we breathe. And oh, by the way, the EMRs are different in every setting. The rules and regulations and payment models are different in every setting. So next time you hear about, on the government side, Medicare for all or a global payment for post-acute, these are fun words. It's fun to think about it. It creates debate. It ain't going to happen in a very long time, if ever. Creating a central payment for post-acute means you first got to fix every single segment of post-acute before you think about how you're going to create one payment across all of them. So let me switch gears, because one of the things that I've been fortunate in my career is to work and experience a combination of settings that is unusual to put together, and it'd be, physician, biotech, hospitals, creator post-acute companies, payer, this, that, and the other. And along the way, I've had many, many interactions with VC and PE-backed companies and sort of innovators, for which I'm trying to be one on the side right now. And I've learned, I have some observations. Anyone in PE or VC before I offend few? Okay. And look, so here's the thing, or at least my simpleton explanation of what I see going on here. Where there's blood in the water, there are VCs. And I don't even mean that negatively. I spend a lot of time studying where VCs and PEs are focused, because they're very smart people. And they're seeing problems and ways to solve problems quicker than the average individual in healthcare. And so where you see them focus, you should be thinking, where should I focus also? Or think about ways to run the other way into spaces that are a little less penetrated. That's another way of thinking about it. But there is an unbelievable amount of money flowing into healthcare. It's astounding to me that the system is broke, yet we're creating billionaires, millionaires, very successful folks. And why is the question, right? And I think a lot about that. First, let's talk about how many, right? If you go out, and these are a little outdated, but if you go on Google and search venture scanners in healthcare, you'll get all these types of images. But this is one based on a digital health venture scanner that lists 771 companies across a number of categories in digital health. Then I did health technology, 1,100 companies, which is no doubt a subset. AI, 725 companies. Let's get back to the concept of payer, purchaser, consumer, stakeholder, end user. All right. So what I see happening in VC and PE, and what I see entrepreneurs doing and failing at regularly, is an entrepreneur. I'm obviously generalizing. I've seen, of all the things that fail entrepreneurs in healthcare, the number one thing that I continue to see is they worry about how I'm going to get paid last. They're so incented by the product and solution and the vision, because at the end of the day, that's what we all want to do. We want to create change for us and for others, and the quest for change drives the passion around the product. And typically in healthcare, you commonly hear, personally affected by this, I had kidney issues, now I have a dialysis company. I mean, you see real reasons why people are trying to do things in healthcare. But at the end of the day, how you get paid drives everything in healthcare. And the graveyard of entrepreneurs is because they worried about reimbursement last. And the 4 Ps that we learned about in consumer products good doesn't even apply to healthcare, because reimbursement with the big R isn't really even in it. So what do you think, what I see happening in VC and PE is lots of of technologies geared to making the patient experience better, yet focus groups with patients seems to be absent from their development cycle. So they think about ways to solve problems from the boardroom on out, so the patient on up, and then they run to the insurance company to sell their solution because those are the people that got the money. So the insurance companies, and they're getting better, but I was in the early days of Highmark that made really the first couple that I saw super interesting approaches at shared savings types arrangements with technology companies. And two well-known public examples are NavaHealth out of Nashville and Aspire in the area of palliative care also out of Nashville. And the concept of shared savings, which is on the Medicare Advantage side of the fence, is that we'll pay you for your expenses, maybe, right? We'll float your expenses. And if you, over a period of time, demonstrate that whatever we paid your expenses for saved us money on a cohort compared to a baseline, we'll pay you a share of the savings that we achieved, shared savings. And it's funny that the Blues plans sort of grabbed onto that, and now they realize they're giving a lot of money away, and I don't see as many arrangements around shared savings. But the concept makes a lot of sense for a technology or an entrepreneur service company, because you can get paid essentially your costs with no margin. And for MA plans, you can save 10, 20, 30, 50, $100 million, because if the baseline is nothing, no management of patient population, and you apply in a narrow cohort an intense solution into a population that got nothing before, what do you think is going to happen? You'll see savings. But what I have found is they're not solving anything. They're solving this, whereas you've got the web of other things that are implicated by this. So you may be reducing 30-day readmit rates, which is what payers care about, I guess, or did. But then you look at the 60 and 90-day curves, and all you've done is create a hockey stick a little later, right? So you got companies walking away with tons of cash, but really isn't solving for anything. So you got people running to the payer. Payers are getting better, but I would say 4 or 5 years ago, a bunch of spaghetti against the wall. We'll try a couple things. You get pilots, this, that, and the other. You get a few of them that haphazardly are selected for pilots, and they I've seen many of them work. They then, in the area where their members are seeking care, hospitals, will mandate or will tell the technology company, I want you to focus here. The technology companies will then run into the hospital, uninvited, and try and create integration with the hospitals for only the plan that's paying them, even though the hospital treats all plans. And then ultimately, the hospital doesn't care or isn't really on board. They're not getting any money for this. So it becomes an overcomable barrier, or a barrier that needs to be overcome. And then only the members or that patient subset for that insurance plan in those hospitals will get the technology or solution over a period of time. You're skipping the purchaser, right? You're skipping the stakeholder, you're skipping the consumer, and you're essentially running right to the payer. And so you've got this massive disconnect between technology companies and the ultimate people that are impacted by it. And you're starting to see more arrangements where the payer is sharing the dollars back with some of the other stakeholders so that they're complicit with what we're trying to do, which is the right evolution of these models. And I'm going to go back to picking on and making fun of us in healthcare. I've said it a couple times, I'll say it differently, and it's small, I'll read it for you, for those in the back. But I am very frustrated in healthcare on an ongoing basis that we try and oversimplify solutions for what is an enormously complex problem. And we use buzzwords, pop health, as an example. And it's maddening, because if you want to really solve for stuff in healthcare, let's roll up our sleeves and start to really figure out what's going on here, and then figure out which piece we can most impact and go after it, right? And so about a year or two ago, I started hearing, we all started hearing about blockchain, right? Cryptocurrencies, I'm sure, all this stuff, blockchain, AI, crypto, this, that. So blockchain in healthcare. And that was the word that was going to change the air that we breathe. And so this is a comic, and I'll add some comments after it. This is, on the left, venture capitalists saying, despite your cool ponytail, you seem to have squandered our investment, to the entrepreneur. The VCs then say, you'll get no more funding unless you mutter empty internet words that make us swoon, and the entrepreneur says blockchain. And this is what I see in healthcare. I see us jumping towards the one word, the one solution, the one thing that's going to change the air we breathe. I have a 412 zip code from Pittsburgh still, and because of the environment with UPMC and Highmark, every other call that I get, one is for someone I want to talk to that I actually know. The other is a IVR, a voice recording from a machine learning AI bot type, asking me if I want health insurance. Right? I don't even live in Pittsburgh, right? And obviously the answer is, if I did, it wouldn't be Pittsburgh-based insurance. I am seeing a sickening amount of IVR, bots, chats, holograms, avatars touted as the way we're going to fix our ability to engage patients. And I'm not saying that's not going to help. I think there are many ways to introduce technology into healthcare that will be incredibly effective. But it is both lazy and insincere to what you would want for your own healthcare, in my opinion, to suggest that if you're sick and depressed and hurt and lonely and this and that and the other, that you're going to want to press a button and an avatar of your personal liking characteristics is going to pop up and you're going to talk to that individual. I have 3 kids under 10. Nothing drives me nuts more than Alexa. You put Alexa into a room with 3 children, and the amount of repeating that has to be done, the wrong answers, and this, that, and I'm sure it will get infinitely better. But my message to you is, and this is a personal opinion that I'm obviously projecting, in my opinion in healthcare, we need to think about ways that technology will enable better humans, not how humans are going to get smarter enabling better technology to replace more humans. The lazy response that we're going to replace humans and human interactions and human-to-human interactions is a reflection of where we're going as a society a bit, but to me it's not there. So this wasn't about me talking about Lacuna, but let me just wrap in some of the ways that we're going about solving this. And this is to my comments that we spend an enormous amount of time thinking we can solve the air we breathe, right? And we're forgetting the easy stuff. When I go to pitch accountable care organizations for my current company, one of the first things I do is I go to their website. And accountable care organizations are risk-bearing, value-based organizations. They save money, they get paid by the government, they get to split the savings with the government. So they are entirely incented to create a model where they're saving money. This actually may be North Carolina, but I took off any identifiers of this ACO. I went to their website, and you can't see it, but hours of operation, 8:30 to 5. I'm sorry, SHIT happens at night. So you want to engage patients to create cost savings, you don't shut down at 5. It costs money to hire people after 5. I get it. Call to action. Contact your primary care physician, who's also 8:30 to 5. So the patient can't call you after 5. The call to action on the website, if they even know where to go, is call your PCP. You get a voice recording from the PCP that tells you to go to the ER. How is that the right answer, right? Low-hanging fruit is my point. I'm going to just skip over this. For those of you interested, I can talk to you after. But the government has put into the marketplace a number of reimbursable mechanisms around care management, chronic care management, CCM being one of them, where you can deliver some of this work and get paid to do it. And you're going to see more of these companies going after that. So Lacuna Health, to wrap this up, I came to Kindred to set up an innovation division. What I didn't plan for is Kindred then went private through a private equity transaction. When you're trying to sell yourself, you can't invest in innovation. And so over the last year, Kindred Healthcare has gone private. We're owned by private equity. Along the way, I remain president of the innovation division, which doesn't mean much. I mean, what I really spend my time on is I spun out a company that is entirely focused on engaging patients. It was a historical call center within Kindred Healthcare that was delivering services just for Kindred. I've done this before, and what we did here is spin it out as a wholly owned C corporation so that gave it a name. I went on Google, spent a couple of hours, and Lacuna is Latin for gap or missing piece, which is what I was trying to do in this segment. Signed contracts with Kindred and then turned it onto the marketplace to create a commercialization of those services, leveraging the fact that we've got the ability to prove it out on Kindred, right? And I've focused people onto the parts of healthcare where I think they're missing. Hospital discharge population, discharges from skilled nursing facility or rehab, home health care discharges. 60% of the patients go home from the hospital with no services at all, which makes no sense to me, right? And you go back to why didn't they get services, and I map to the dysfunction associated with the transition when they're ready to go home is not the right time to be making decisions on what the patient needs for the next 90 days. So they get reintroduced into the home. For whatever reason, someone decided, or it wasn't clear, it didn't happen, or it was ordered and never showed up, that they didn't get services. Yet when you look at the complex DRGs like CHF and COPD, for that population, they're north of 50%, right? So focusing lower cost, high value solutions towards the parts of healthcare that I think most need it. Let me quickly just show you a little bit of the data, and again, it's small, so I'll talk through it. We serve 87 hospitals right now, right? And this is not meant to be a commercial as much as an illustration of how the low-hanging fruit can be addressed. We serve 87 hospitals in a post-discharge model. We're paid by the hospital to follow a patient population for a period of time. And what that means is we've got 45 RNs, registered nurses, licensed practice nurses. We were all RN under the Kindred model. We've moved more to an RN-led or oversight model of mixed clinical labor force, because the market simply can't afford all RNs, and in many cases you don't want an RN on the phone dealing with scheduling, right? So to have an RN engage the patient first, make sure that they're not clearly complex, and then oversee medical assistance and such on an ongoing basis is, I think, what will work in the market, right? And so what happens? So the left is a stroke population for, in fact, University of Louisville, which will have a white paper that will be downloadable shortly off of the website. 45-day follow-up stroke population from the stroke center of the acute care hospital. 45 days. So the number one gap that we identified over a period of time was the lack of a primary care appointment. So the system has paid for the acute care episode. They've discharged them. They wrote what I did, discharged home with 2 weeks meds, follow up with your PCP. Patient goes home, or more often they go to a rehab, a skilled nursing facility, and then home, and they don't have a PCP. And so it gets broken down even further. Half don't have a PCP at all. The other half don't have it within 7 days. The literature is very clear that if you don't get back to the primary care within 7 days, 7 to 14, your chances of getting readmitted are exponentially higher. For a stroke population, if you don't get back to the neurologist within 3 weeks, the literature is clear that you're going to have something bad happen, or at least the chances go up. Number one gap, lack of primary care appointment. As you go down, medication obtainment and education. Patients are confused, not surprising. No one's there to help them. They call the primary care office. If you're lucky enough to be able to talk to a doctor for 30 seconds, great. Mostly you're going to end up having to schedule an appointment to go see the doctor, even get your meds, questions, and answers, yet you've only been given 2 weeks of meds. So, and you've got 6 more on the counter that no one knew about. Depressed, fall risks, all happens after a hospital. They've just had an acute event. If they weren't depressed before, what do you think the chances are now? You think the family's going to help? Many of these cases, they're depressed too. Right? And the support systems are not enough to support someone also. DME, durable medical equipment, home medical equipment. COPD patients get ordered oxygen. I can't tell you how much this happens. Oxygen gets delivered. If you go into the home of a patient, I encourage you to do if you're trying to develop the technology, you'll see tanks everywhere. And when we call, what happens? I don't want to turn on the tank. What am I supposed to use this for? They're asthmatic. They get a nebulizer. They don't know how to use it. They don't know they actually have to pop meds into the actual cannula. Right? Ordered home health care. Doctor thinks they've done their job. Hospital, great. Nurse never shows up. No one's there checking on that. So all of this stuff that happens within a couple of days after discharge, with one phone call, we're usually finding things, the first phone call in a 4-call cadence over 45 days, just about everything that's going wrong presents itself within 48 hours. And it's actually a drop-off where we get to 30 to 45 days, we start seeing ourselves as having less of an impact. Most of the impact we have in these post-discharge programs are in the first 2 days. They've been reintroduced in the home, and everything that could go wrong has already gone wrong, and no one's there to actually catch that. Right side is an ACO population, a general hospital discharge population. Same thing. Enormous amounts on a percentage basis of discharged patients that we're connecting with that do not have a primary care appointment within 7 days. This is a skilled nursing facility discharge population. The top bar, again, that's boxed. Lack of a PCP appointment. Skilled nursing facility discharges are a higher acuity patient population, what's happening here is when we're engaging these patients, historically, when something goes wrong, they go back to the ED. That doesn't help anyone. They don't belong back there in most cases. But they're sick enough that they probably need other services like skilled nursing or home health care in the home. No one's there to help assess what's the right setting of care. And so we have skilled nursing facilities paying us to manage gaps, but the reason why this works is it works fee for service because one of the gaps we identify is they need to be back in the skilled nursing facility for a shorter stay focused on therapy. So they get census, therefore they're willing to pay for it. The system gains because they're back in the skilled, which is a lower cost setting compared to the hospital. So when you think about selling into providers, you need to get past the ability that they can pay for it through creating some sort of fee-for-service reason to buy so that you can even get to the stuff that benefits the system that everyone wants anyway. So you can talk out of both sides of your mouth, and you need to, and that's the way to win. Figure out a way to get them to buy it because there's an ROI on the old world economics so that we can get to the exciting conversation was how do we actually do right by the system in the newer world economics. And that's the goal. And I'll end with this and take any questions. It sort of ends with the way I started. We've got really complex patients, and we've got a system that seems to want to put the patients all in the same box. And until we actually divorce ourselves from that lazy, short-sighted thinking and start to do our patient journey mapping from the patient's eyes on up is when we'll finally start to develop solutions that I think will have not change the air consequences, but meaningful advances that over time will stack into things that we actually create sustainable change. So it's been a privilege to present to you. I really appreciate everyone coming out on their lunch hour and be happy to take any questions.